morning everyone. I am Dr. Jigar Panchal, Associate Professor in Cardiac Anesthesia at UNMICRC Institute of Cardiology and Research Center. As a part of continuous cardiac education, today we are going to discuss on management of the pediatric patient after cardiac surgery. Objectives of the today's topic will be to have the knowledge of complications that occur after cardiac surgery, particularly in the pediatric population, and how to deal with that. To understand the effect of cardiopulmonary bypass on different systems and how to manage each and every system post-cardiac surgery. Optimal management of the post-operative pediatric cardiac surgical patients requires a thorough understanding of patient's anatomy, physiology, surgical repair or any palliation. Intraoperative events associated with cardiopulmonary bypass, surgical procedure, anesthesia and medication have multisystemic effect. Post-operative care focuses on anticipating potentially deleterious events and instituting a proactive approach in managing the patients. Intervention strategies are directed at preventing low cardiac output syndrome and avoiding adverse sequelae in major organ system. Post-operative care of pediatric cardiac patients have evolved dramatically with significant improvement in the survival. These improvements are attributable to improvement in diagnostic modalities, surgical techniques, cardiopulmonary bypass support, anesthetic management, and use of extracorporeal life support. Optimal post-operative care requires an accurate preoperative assessment, use of intraoperative findings and data, careful patient risk stratification, and meticulous anticipatory management. Preoperative assessment. It is very essential part. Preoperative assessment is very essential to optimal intraoperative and postoperative management. Assessment should focus on identifying the factors that can be modified to optimize patient's preoperative clinical status as well as those that could potentially affect the intraoperative and postoperative courses. The goal of preoperative evaluation is to collect the data in a systemic fashion to aid in the establishment of accurate diagnosis, for determination of patient risk level, to have the preliminary formulation of postoperative expectations. Preoperative assessment requires a complete review of the cardiac and non-cardiac history, a thorough physical examination, laboratory test, ECGs, echocardiography, and cardiac imaging. A recent respiratory illness or infection can prolong the postoperative mechanical ventilation and ICU length of the stay. Genetic defects or syndrome may have important clinical implications for the perioperative course, like Down syndrome is associated with significant risk of upper and lower airway anomalies. Laboratory evaluation should include complete blood count and serum electrolytes, coagulation profile, liver and renal functions. ECG to demonstrate the patient's cardiac rhythm as well as assess the conduction intervals. Chest radiography is necessary to assess the cardiac silhouette and lung fields at the baseline. Echocardiography is an essential tool in diagnosing the congenital heart disease. It indicates cardiac situs, intracardiac anatomy, myocardial function, AV and semilunar valve function, anatomy of the great vessels, along with pulmonary and systemic venous system. Coming to post-operative care, the intensivist and other members of the critical care team assume post-operative management once the patient has been successfully transitioned to the ICU environment. This transition includes the full monitoring on the ICU devices, appropriate support of the respiratory system, medication infusion administered via appropriate ICU equipment. Handover. The systemic and comprehensive surgical and anesthesia handover is an essential part for the optimal patient management. It is the responsibility of the cardiac anesthetist to monitor the patient's ventilation and hemodynamics until the handover process is complete. Immediate post-operative assessment include complete initial physical examination, assessment of vital signs and hemodynamic parameters, ECG analysis, chest radiograph, laboratory data include arterial blood gas analysis, hematocrit, electrolytes and glucose. A comprehensive OR to ICU handover, it should include patient history, diagnosis and pathophysiology, airway and anesthetic management, the recent dose of anesthetic, paralytic and antimicrobial agents, detailed description of operative findings, the repair procedure, intraoperative complications, cardiopulmonary bypass time, aortic cross-clamp time, deep hypothermic circulatory arrest time, presence of any intraoperative arrhythmias and current infusions, vasoactive agents and inotropes, difficulties with airway management and problems with myocardial protection, need for any arterial or ventricular pacing. Most important is the result of intraoperative echocardiography finding. It should be reported, including the results of repair, any known residual defects and the ventricular function. Ventilation management. First and foremost thing is to ensure that the patient is safely ventilating or not. For that, set the appropriate ventilation mode. Setting should be confirmed by the cardiac anesthesiologist. Ensure the endotracheal tube is secure and patent. Document the size, position and the length at the mouth. Connect end-tidal CO2 monitoring. Check for air entry and chest movement bilateral equal or not and synchronous with ventilator. Record the sat rate, peak inspiratory pressure, tidal volume, PEEP and FiO2. Ensure ventilator and monitor alarms are set appropriately. Also ensure that the oxygen saturation parameters are appropriate to the cardiac condition of the patient. A chest X-ray should be taken and reviewed within 1 hour of return to the ICU. The assessment should focus on evaluation of endotracheal tube placement, lung fields, central venous catheter position, chest tube and drains. Post-operative monitoring. The goals are to establish an objective assessment of each patient's overall clinical status and guide proactive management. The level of monitoring is dictated by complexity of the diagnosis and the surgical repair. Intravascular catheters are placed intraoperatively for post-operative hemodynamic monitoring, non-traumatic blood sampling, and administration of vasoactive infusions, parenteral nutrition and volumes. All patients should have continuous ECG monitoring, invasive blood pressure monitoring, respiratory monitoring including pulse oxy and EtCO2 monitoring for ventilated patients. Assessment of urine output is essential in the immediate post-operative period. Central venous pressure monitoring is standard for most of the patients. RA pressure monitoring provides a continuous assessment of the filling pressures. Low RA pressures in hypotensive patients may suggest need for fluid resuscitation. Elevated RA pressures may be an indicator of cardiac tamponade, poor RV function or compliance, or an acute process such as pneumothorax. Hemodynamic monitoring. To ensure the patient is safely monitored, one should ensure that the ECG monitoring is attached. Continuously observe all the invasive lines in situ for the both accurate and normal waveforms. Ensure all pressure transducers are continuously flushed. Level all the pressure transducers to the right atrial level and zeroing should be done once a shift. Realign the transducer whenever the patient is repositioned. Ensure all the peripheral pressure lines are labeled appropriately. Ensure alarm limits on the monitor are appropriate to the parameter set and that arrhythmia alarms are switched on. Record all the vital signs and invasive pressure 1 hourly. Most important is thermoregulation. Although the temperature instability is common in perioperative phase, the goal of temperature regulation is to maintain the normothermia. There should be central and peripheral temperature monitoring, especially for the infants. Record each temperature hourly as well as score toe gradient between two. The rectal probes are used for central monitoring. Insert the probe not more than 2 to 3 cm into the rectum. Over-insertion may cause bowel perforation. A mild degree of induced hypothermia may be useful in treating certain tachyarrhythmias. However, the low body temperature contributes to increased SVR and PVR, coagulopathy and bleeding. So the gradual rewarming of the patient should be done with radiant warming devices. Same way, aggressive treatment management is crucial to avoid adverse effect of hyperthermia, and it includes treatment with antipyretics and surface cooling. Coming to the respiratory management, positive pressure ventilation may exert effects on myocardial function especially on systemic venous return, RV function, PVR and cardiac output. The key to the optimal mechanical ventilation is to adopt the strategies to achieve the optimal gas exchange and tissue oxygenation while minimizing the adverse effects on hemodynamics. Ensuring adequate level of analgesia and sedation and providing measures to minimize the pain, agitation and ventilator asynchrony with the onset of spontaneous ventilation to improve the level of comfort and reduce the excessive work of breathing. The most common approach is early extubation. The advantage of early extubation include minimizing the need for post-operative sedation, reducing the incidence of nosocomial infection and reducing the length of ICU admission. Low cardiac output syndrome is a common post-operative complication after cardiopulmonary bypass and occurs within first 6 to 12 hours after surgery and is defined by signs and symptoms of tachycardia, poor perfusion and oliguria. Factors account for low cardiac output syndrome are hemodynamically significant residual lesions, myocardial ischemia secondary to circulatory arrest and hypothermia, reperfusion injury, insufficient intraoperative myocardial protection and cardioplegia, inflammatory response to the cardiopulmonary bypass, arrhythmias and cardiac tamponade. Frequent assessment of cardiac output is accomplished by monitoring heart rate, blood pressure, intracardiac filling pressures, peripheral perfusion, temperature, acid-base balance, mixed venous saturation and urine output. The treatment modalities are maintaining the adequate preload by fluid resuscitation, appropriate use of inotropic agents to support the myocardial contractility, taking measures to decrease the SVR and enhance the cardiac output, and extracorporeal membrane oxygenation (ECMO) may be a consideration for progressive myocardial dysfunction refractory to the conventional therapies. Postoperative arrhythmias. The physiological stress of the cardiovascular surgery, it increases the incidence of arrhythmias. The contributing factors include anesthesia itself, CPB, hypothermia, surgical incision, hemodynamic instability and circulatory catecholamines. The most common arrhythmias are supraventricular tachycardia, ventricular tachycardia, junctional ectopic tachycardia and complete heart block. Junctional ectopic tachycardia is the most common post-operative arrhythmia in infants and children less than 2 years. JET is characterized by narrow complex tachycardia with rapid ventricular rate, gradual increase in the heart rate. P wave is usually inverted and may occur before, during or after QRS complex. The treatment modalities for JET are simple cooling measures, ensure babies are not warm, not overwarm, ensure adequate analgesia and sedation, inotopes should be reviewed, check blood gas and electrolytes and make corrections, medical therapy in the form of amiodarone and ivabradine. Pulmonary hypertension. Elevated PVR and resultant pulmonary arterial hypertension is a common post-operative complication. pH can acutely elevate the RV afterload with resultant RV dysfunction and is a common cause of cardiac arrest in the post-operative patient. Risk factor includes effect of CPB, excessive pulmonary blood flow with left to right trend, elevated pulmonary venous pressures, lung pathology and sometimes protamine. These multifactorial events predispose to the patient to the acute pH crisis with resultant decrease in the cardiac output, acidosis and hypoxemia. In the acute phase, the measures are instituted to reduce the pulmonary artery pressure and avoiding precipitating factors. These measures include maintaining alkalosis, optimizing ventilation and oxygenation, supporting cardiac output and treating RV failure, providing optimal analgesia and sedation, intravenous afterload reducing agents such as melanon or sometimes inhaled nitric oxide. Fluid and electrolytes. The assessment of fluid status is multifactorial and it includes the monitoring heart rate, filling pressures, blood pressures, urine output, acid-base balance. Intravenous fluids should be prescribed as per the IV fluid guideline. All the children have accurate fluid balance recorded hourly. On return from the theatre, all the volumes on syringe pumps should be cleared, urometers should be emptied, and PD catheters are connected to the free drainage. Serum glucose and electrolytes are measured within the first hour following surgery and every 4 to 6 hours thereafter. Serum glucose level is closely monitored in neonates because of hypoglycemia may depress myocardial function. Serum sodium level at less than 125 milliequivalent per liter is a risk factor for seizures. Calcium acts as a positive inotrope affecting the contractility of cardiac muscle, vascular smooth muscle and skeletal muscle. Most common electrolyte disturbance in the post-operative patient is hypokalemia, which usually manifests in the rhythm disturbances. Hyperkalemia may occur with severe post-operative renal dysfunction, with acidosis, or in patients receiving excessive potassium supplements. Treatment for both the condition, hypo or hyperkalemia, should be started as early as possible. Coming to the renal system, urine output is monitored as an indicator for renal perfusion and cardiac output. Minimal urine output in pediatric patient is 0.5 to 1 ml per kg per hour. In the post-operative phase following CPB, urine output may be sufficient due to stress response of the surgery, intraoperative fluid administration, and an osmotic diuresis from the elevated glucose levels. Within several hours post-operatively, urine output usually diminishes. Diuretic therapy is usually initiated on the first post-operative day after initial adverse effect of CPB diminishes. If there is no sufficient urine output after diuretics, then one may consider for peritoneal dialysis when the preload is optimized. Coming to the neurological systems, intraoperative or postoperative events that are associated with cardiac surgery have the potential to cause the adverse neurological sequelae. Risk factors are anesthesia, acidosis, electrolyte imbalance, hypoxia, embolic events, CPB, deep hypothermic circulatory arrest. Neurological assessment includes frequent evaluation of pupillary response and autonomic liabilities such as hypertension and tachycardia in the chemically paralyzed patients. Once the effect of muscle relaxants no longer persists, the clinical evaluation of the neurological integrity includes assessment of eye opening, motor, and verbal responses. Analgesia and sedation. It may be difficult to assess the anxiety and the pain in the chemically paralyzed patients. The physiological parameters, hypertension, tachycardia, diaphoresis, and pupillary response are useful. Once the effect of muscle relaxant have dissipated, response to painful stimuli, fluctuation in the respiratory movement, guarding, and facial grimacing provide the additional information regarding the patient's comfort. Developmentally appropriate pain scales are effective in assessing the level of discomfort. Combination of opioid analgesics and benzodiazepines provide efficacious post-operative analgesia and sedation. Infection. Prophylactic antibiotics are used to reduce the risk of pneumonia and bloodstream, urinary tract, and surgical site infection. A broad spectrum antibiotic should be given before surgical incision and continued in the immediate post-operative period. Preventive strategies for the reduction of post-operative infection include strict adherence to the sterile techniques, prompt removal of invasive lines, catheters, and tubes. Fever in the post-operative period should be treated aggressively, and if fever persists, blood cultures are obtained to identify the specific organism. Nutrition. Enteral nutrition in the post-operative period following the congenital cardiac surgery provides essential nutrients and improve immune response. The nutritional goal of enteral feeding in the infant is 120 to 150 kilocalorie per kg per day. Enteral feeding should be initiated at 1 ml per kg per hour for the patients weighing less than 25 kg. Assessment should be made at 4 hours interval and include the abdominal girth, residual aspirate, and any episode of gastrointestinal distress. If tolerated, the feeding may be advanced to 2 ml per kg per hour for the children weighing less than 25 kg. It's a special condition where the patients came with the open chest. A child with an open chest should be kept comfortable and well sedated. They should remain on the appropriate ventilator mode, and the ventilation should not be weaned until after the chest is closed. The transparent dressing should be applied and the chest is covered with gauze laid on the top of the dressing and marked with the chest open sticker. Observe the patch regularly for bleeding, bulging, or any pressures. Drains will remain until after the chest is closed. Some of the special consideration. One example is patients with significant chest tube or surgical site bleeding, which is refractory to the blood products administration, including platelets, cryoprecipitates, and fresh frozen plasma. Once the medical bleeding has been corrected and still the active bleeding continues, a surgical lesion must be considered. Close communication with the surgeon throughout the process is very important. Another condition is requiring re-operation is shunt-dependent patients with an acute shunt occlusion. With the shunt-dependent pulmonary blood flow, an accurate desaturation without clear explanation and resolution requires prompt evaluation of the shunt by echocardiography. Once the shunt malfunction or the occlusion is suspected, evaluation and therapy must be initiated promptly. Appropriate therapy includes aggressive fluid administration, heparin bolus followed by continuous infusions. Unless the shunt occlusion is being ruled out with the initial evaluation, the surgical exposition is the appropriate next step. To summarize, intraoperative and postoperative events have the potential to produce adverse multi-system sequelae. Comprehensive postoperative management focuses on an approach in preventing the deleterious effects of CPB and intraoperative events. A disciplined approach to the assessment and integration of clinically, laboratory and physical examination data is essential. Thank you.